I'm Dr. Craig Escudé, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
The IDD Health Matters Podcast is a joint production between Friends for Life and Intellect Ability. For more information, go down into the show notes and click the link where it says Learn More Here.
Welcome to this edition of IDD Health Matters. Our guest today is Val Bradley with HSRI. Welcome, Val.
Thanks.
So, Val, tell us, what is HRSI and what is your role with the organization?
It's HSRI.
Oh, that's a good start. HSRI.
Yeah, it's the Human Services Research Institute. Started back in 1976. Myself and a couple of colleagues launched HSRI as a nonprofit policy analysis organization. And for me, it was based on experiences in the IDD and mental health field. At that time, specifically concerns around deinstitutionalization, how we create community supports for people with disabilities. Having spent, a long time going through institutions in my career and being radicalized, if you will, about the need to get people out of those places and into circumstances that were more normal.
I bet you've seen some very interesting things over the years of doing that work. Do you have any notable success stories?
Well, that's a good question. I mean, I think that the whole deinstitutionalization movement is a success story. I haven't looked at the recent statistics, but we've significantly reduced, if not eliminated, large remote public institutions for people with disabilities.
There still are a few, I believe, but they have definitely reduced
absolutely
greatly for very good reasons.
And I think, unlike mental health, we did a much better job of creating places in the community that really provided residential, employment, other kinds of support. I'm afraid, having also been associated with some of the deinstitutionalization in mental health, we weren't nearly as good as planning for all the needs that those people would have coming out of facilities. So I think as a general matter, you'd have to say that the movement over the last several decades is definitely a success. Do we still have a long way to go? Absolutely.
So with the great things that have come from deinstitutionalization, are there some challenges that you've seen arise that maybe you could see that maybe still need to evolve or still need to move in a better direction? Any specific things that were challenging in the process?
It's interesting. AAIDD asked me if I wanted to do a brief webinar. They're doing a series of webinars on various topics. And I said, well, I'd love to do a webinar on I wish I knew then what I know now about
Why don't you share a couple of tips from that upcoming webinar?
Well, for one thing, we really basically replicated small institutional settings. When we placed people out into 16-bed, sometimes 30-bed group homes, those really weren't community homes. They were based in the community, but they weren't in the community.
I know what you mean.
So we had to really go through a second round through money follows the person, et cetera, to get people out of the large homes into smaller homes. So that was one thing I think we didn't foresee.
Let me stop you there. Do you think that some of the smaller homes still operate with an institutional mentality, or is the mindset really changing to be community-based small homes?
Well, one of the things that's certainly urging providers to create more home-like, or home settings, not home-like, is the settings rule.
Right. Touch on that a little bit.
Well, way back in 2014, CMS issued something that they called the settings rule, which was a big deal for the Centers for Medicare and Medicaid Services, because prior to that, the waivers really came to be back in the 90s. And
just to touch, and I've said this before, but a waiver allows people to receive supports and services that used to only be able to be delivered in an institution, but it allows them to receive those same supports and services in a community-based setting.
Exactly.
I always like to explain things just a tad.
Exactly.
Yeah.
And it really the waiver program undid the Medicaid bias that really meant that you could only spend Medicaid dollars in an institution. Yeah. So that broke a huge logjam. It's still not an entitlement as such, so states still have waiting lists for those places. Anyway, up until 2014, CMS had been pretty hands-off on being prescriptive about what waiver support should look like. There were some basic assurances that states had to follow in terms of plans of care and eligibility standards, making sure providers were certified. But CMS really didn't get into sort of how the program operated and what the rights of people were within it. And so the settings rule really required providers, especially those providers where they own the homes, to give people the right to choose their own schedules, to have privacy in their bedrooms, to have a key to the place. And there were all sorts of requirements around person-centered planning.
It's all things that any of us want in life, right?
Well, yeah. I have to say one of my formative experiences, because I'm old, is reading Normalization by Wolfensberger, which I read shortly after it came out in the 70s. And basically what Wolf was arguing then was the more we treat people in circumstances that don't reflect the circumstances we all live in, the more you associate stigma with those people. So oddly, the settings rule, in my judgment, I haven't heard too many people say this, is really based on the notion of normalization, because it's introduced by saying people who are on Medicaid and home and community-based waivers should experience the same quality of life, the same community experiences as people who aren't on Medicaid. So the settings rule was a big deal.
So how are we doing on that as a society?
Well, I have the luxury of a long view because I started in this field in the 60s, working for the California legislature and working on big reforms in the mental health world and in the DD world. So for me, the sweep of history is extraordinary. Where we've come is astonishing, from seeing people at Pennhurst State Center 10 rows of cribs, 30 different columns of cribs with people, adults who hadn't really moved for many years and contractures, to seeing people living reasonably ordinary lives in community settings. That doesn't mean we still don't have work to do. We still have waiting lists. We still have a huge workforce crisis, which I think at the moment is the biggest restraint on really improving our services.
Well, I think that's such an important perspective, because for people who maybe are newer to the field, it may seem like there hasn't been much progress. But really, when you go back, there has been a whole lot of progress.
Oh my God.
Again, we can always say we've still got work to do.
Yeah.
But certainly there have been a lot of progress, a lot of improvements in that way. So let me ask you this. Did you notice anything as people moved out from larger institutional settings to community-based settings that related specifically to access to healthcare? Any challenges in people finding good healthcare, or improvements, or anything you can touch on related to health?
Well, I think it's absolutely the case that the general health community was not used to, by any means, of supporting people with intellectual challenges,
sure,
behavioral challenges. So it's taken a long time, and it's not perfect, to go back to how doctors are trained, especially through UCEDS, University Centers for Excellence in Developmental Disability.
There's so many letters in this field.
Yeah. And those centers do really work to infuse information about people with IDD into doctor medical curricula.
I was one of those people as a physician in this field when I first started back in the 90s and became a physician at a large regional center. I realized very quickly that was not trained to provide healthcare for people with disabilities. And that's really what I really work towards now, is to try to provide training and get training into schools and health professional schools, all about, because it is a real need. And I just think it's fundamentally important to us as a society to have healthcare providers that can provide at least a basic level of competent healthcare to people with intellectual and developmental disabilities. So I echo that observation from my own personal journey as well in life.
I can appreciate that.
Yeah. So Val, how did you get into this field?
Well, like a lot of people in our field, I had a personal experience of disability. My grandmother, after a week at Camarillo State Hospital, died there because she was going through withdrawal from barbiturates, and they had no idea back then how to handle barbiturate withdrawal. And they took her off cold turkey, and she died a week later.
Wow.
Secondly, I had a first cousin with very severe epilepsy. So, like a lot of us, we have family attachments.
Sure.
And then I went to work for the California legislature as a staff person in the 60s, and was drawn into, really by happenstance. I could have been drawn into prison reform but I became, a key staff person for some major reforms in the DD world and in the mental health world. And because of my personal experience, it certainly resonated with me. In the 60s were, the civil rights movement, lots of excitement around pushing rights issues. And so it really resonated with me, and I've been in it ever since.
Well, you have quite a reputation in this field, quite a good reputation in this field.
It may be mixed in some quarters.
An excellent one. And it's wonderful that you're here to share some of your insights.
Friends for Life Residential Care, specializing in support for individuals with developmental disabilities, offers services like adult day support and home health care. Emphasizing empowerment and quality of life, we live by the motto, "My ability is stronger than my disability." We are currently hiring, welcoming those passionate about making a difference. Learn more and explore career opportunities at friendsforliferc.com.
I'm Dr. Craig Escudé, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support.
So one of the things I like to do with guests is something I call 3 in 3. It's 3 things in 3 minutes, and I'm not going to hold you to 3 minutes.
That's good.
It's just a catchy phrase. But can you talk about maybe 3 points, 3 tips, 3 words of wisdom, 3 pieces of advice that you would like the listeners to know about, either about this field or things that you think that can improve the world of supports and services or health and wellness for people with intellectual and developmental disabilities?
Certainly, I think one thing that we're really going to need to rely on over time is improving self-direction for people with disabilities.
Explain self-direction just a tad. What does that mean?
Well, it's really moving to a retail system from a wholesale system, because
I like that.
By and large, when people enter the IDD service system, they're slotted into a day program, a residential program. Now, they presumably have choice of which of those programs they go to, but they have very little control over how the resources are deployed. In self-direction, the individual is given a budget over which they have control. So they can use that budget, obviously within the rules of the waiver.
And with supports from people around them.
Case managers.
And maybe their family.
Exactly. Support brokers.
Make those decisions.
Absolutely. And they can then hire their own personal staff. And depending on the state, there are more or less requirements about who those staff can be and what kind of screening process they should go to. But in some ways, it really does address the workforce crisis because individuals can tap into networks, family and friendship and relationship networks, and find people who wouldn't necessarily be part of the employment pool for other kinds of
makes sense.
Residential and day programs. So I think self-direction really of necessity, both because it's a good idea, because it empowers the individual and the family to make choices that are individually tailored. But I think it also is one way we could address the workforce crisis. Yeah, the next thing we have to pay attention to is the workforce crisis. And,
it's a big one. And it affects more than just people with intellectual and developmental disabilities. It's anyone who might need some sort of support in their lives, which is most of us at some point.
Oh, you bet.
Yeah.
When I was on a plane coming out here, I was sitting next to a man whose mother now is in memory care, and that memory care operation is having a heck of a problem finding staff. So, he, as you say, it's everywhere.
So what's your solution?
Well, we do know some of the things that work. We know that training and credentialing helps staff stay around.
Yep.
We know pay and benefits. We know organizational culture is important so that the direct support professionals feel supported, valued, recognized.
Someone mentioned years ago to me when I was very broke that people don't work for money. And I'm like, I'm here for money. I need money. But I understood what they meant. People, when they feel valued in a place, mm-hmm. when they feel like they're appropriately trained and supported as an employee in a particular environment, they're more likely to stay there. If the money's the same somewhere else, they're going to choose a place where they're better trained, where they're better supported, the work environment is good. So that's kind of what you're talking about.
Absolutely.
Yeah, money's important. You got to pay people what they're worth, and I think we've got room to improve on that.
We do. So, I mean, given the demands that we put on support workers.
But even with that, the other components can certainly help people to stay in the field.
Yeah, exactly. Yeah. So third thing, I think we've done a lot of work on the front end of establishing services, developing various service modalities, provider networks. My concern is we don't do enough about understanding the impact of those services. We don't spend enough time looking at the data, the information that tells us whether people like what they're getting. We're spending a heck of a lot of money on these services.
Very true.
Are they getting people employed? Do people have friends? Are they making, do they have relationships? Are they in their communities? Are they healthy? Do they have access to health services that really meet their needs? So I'm as concerned with the back end, meaning how you really understand how the system is functioning. And, in a lot of states, a lot of public administrators aren't trained to look at data. And so we really need to build in that competency over time and also help them engage stakeholders in reviewing the data and understanding it. And then deciding, looks like we've got a problem here. What do we do about it? So those are my three things.
Well, those are three excellent things for all of us to ponder and for the field as a whole to work towards. Val, thank you so much for taking the time to talk with me today. And more importantly, thank you for the incredible work that you've done in this field.
Well, I've enjoyed it. Thank you.